Greetings, folks. In this video, we shall discuss about Kawasaki's disease. Kawasaki's disease is also termed as mucocutaneous lymph node syndrome. It is a generalized systemic vasculitis of unknown cause, along with Shirley purpura. Kawasaki's disease is one of the principal pediatric systemic vascular diseases and is the leading cause of acquired heart disease in North American and Japanese in children. It affects infants and children less than 5 years and most commonly occurs in endemic and also community-wide epidemic forms. There are seasonal variations which occurs more in the late fall through early spring, both in North America and Northeast Asia. Male to female ratio is 1.5 to 1, and there is increased risk of occurrence of Kawasaki's disease in the siblings. Coming to the clinical features, the diagnosis is clinical. So the criteria are different because there is a complete one, incomplete. So before that, these criteria can be applied only after excluding the other diseases, like similar findings such as viral illness such as measles, adenovirus, enterovirus, bacterial illness such as cervical adenitis, scarlet fever, staphylococcal scarlet skin syndrome, or immune-mediated syndromes such as serum sickness, Stevens-Johnson syndrome, and toxic shock syndrome. The cardiac complications are most severe manifestations of the Kawasaki's disease, and it includes coronary artery aneurysm, myocarditis, pericardial effusion, valvular dysfunction, and LV dysfunction and arrhythmias. So the coronary artery aneurysms or ectasia occurs in around 15 to 25% of the untreated children and can lead to myocardial infarction, sudden death, or ischemic heart disease. LV dysfunction is seen in almost half of the patients. Non-cardiac findings of Kawasaki disease include arthritis or arthralgias, vomiting and abdominal pain, high drops of gallbladder, extreme irritability due to systemic inflammation, aseptic meningitis, urethritis, desquamating rashes in the groin as compared to the desquamation of the fingers, toes in weeks 2 and 3 of illness. So these are the non-cardiac findings. So you can find all the systemic manifestations like joint pains, abdominal pain, extreme, then skin manifestations, and also the head drops of gallbladder too. So the diagnostic criteria for Kawasaki disease can be classified into 3 types: the classic or complete form, the incomplete Kawasaki disease or atypical, and also the epitypical Kawasaki disease. So coming to the classic or complete Kawasaki disease, you can see that the fever is for 5 days, must be for 5 days, and also it must satisfy the 4 following clinical criteria. The criteria are bilateral bulbar conjunctival injection without, this is important, without any exudate, erythema and cracking of lips, strawberry tongue, and erythema of oral and pharyngeal mucosa. Rash will normally be maculopapular, diffuse erythroderma can be seen, or erythema multiforme like. And erythema and edema of hands and feet can be seen in acute phase, and or periungual desquamation can be seen in subacute phase. Okay, so erythema is seen and edema is seen in the acute phase of the hands and feet, but periungual desquamation is seen in subacute phase because it spreads to the surrounding tissues. You can remember like that. And there will be some cervical adenopathy, lymphadenopathy, which is around more than 1.5 centimeters in size, usually unilateral anterior and cervical, non-fluctuant. And incomplete Kawasaki's disease, fever for 5 days, 2 to 3 clinical criteria of classic Kawasaki's disease should be seen, and along with that, CRP must be more than 3 milligrams per liter, and or ESR must be more than 40 millimeters per hour. Okay, it must be more than 3 and is 40. So, and along with it, there may be positive echocardiogram or more than or equal to 3 supplemental labs, such as like albumin less than 3 grams, anemia for the age, liver involvement with elevated ALTs like alanine, aminotransferase, platelets more than or equal to 450,000 per millimeter cube after 7 days of fever onset, and the WBC count of more than 15,000 millimeter cube, and presence of pyuria more than 10 WBC cells per high power field. This is the incomplete one. So we'll more rely on the lab criteria and 2 to 3 clinical criteria rather than the at least 4 ones. So, and atypical ones meets all the clinical criteria for complete, But along with that, patients additional features not typical, like child with Kawasaki syndrome and nephrotic syndrome. So these are not classical feature of Kawasaki disease, right? So they can be atypical Kawasaki. So the cardiac complications of the Kawasaki's disease include in acute phase there might be myocarditis, pericarditis, coronary arteritis, arrhythmias, and in subacute phase there might be coronary artery abnormalities, and in convalescent phase, like that is 4 to 6 weeks, coronary artery abnormalities can also be seen. The Kawasaki's disease is divided into three phases. The acute febrile phase typically lasts for my first 2 weeks of illness. The subacute phase lasts for 2 to 4 weeks, and the convalescent lasts for 4 to 6 weeks. The total duration is for 4 to 6 weeks. The laboratory results are non-specific in the acute phase, but for those children who do not fulfill diagnostic clinical criteria, the supplemental lab abnormalities lend support to the diagnosis. Additionally, there may be elevated plasma lipid and elevated gamma glutamyl transpeptidase. Thrombocytosis is not usually noted until the second week of illness, and cardiac complication, as we have discussed, there can be anything. And patients less than 1 year old and those more than 9 years old tend to present with incomplete Kawasaki's disease, and leading to delayed diagnosis and higher risk of coronary artery abnormalities. Other risk factors include higher platelet counts, higher CRPs, lower albumin. Due to importance of the identifying patients at risk of developing coronary artery abnormalities, cardiovascular biomarkers will become important for diagnosis in the future. So one biomarker is NT-proBNP, is increased in the Kawasaki's disease and in Kawasaki's disease and incomplete Kawasaki's disease compared with the febrile controls. The acute phase of disease results in myocarditis and pericarditis, which typically resolves without treatment. The most common cardiac finding is include tachycardia out of proportion to the fever and gallop rhythm. Inflammation of the aortic valve and mitral valve can lead to murmurs of valvular incompetence, and usually during the acute phase of disease. Pericardial effusions are rarely large or life-threatening, and reduced LV dysfunction and arrhythmias are more common in the acute phase of illness than in the later phase. Although coronary arteritis begins during the acute phase and aneurysms can be seen as early as 6 days after the fever starts, most coronary aneurysms develop during third and fourth weeks. Okay, so aneurysms of the arteries other than coronaries, such as subclavian, brachial, iliac, and femoral, can also develop, but they are rare. The myocardial infarction is a complication of the coronary artery aneurysm and is the leading cause of death in the Kawasaki's disease. And majority of the infarcts occur in the first 6 months of the age, but may present later on also. So echocardiography should be performed during the acute stage of disease and repeated in the subacute and convalescent stages and beyond. Findings include pericardial effusion, then poor ventricular function, aortic or mitral valve regurgitation, perivascular brightness of the coronary arteries, acute phase, and coronary artery aneurysms. The treatment part is very interesting. So in this, we don't know the cause also of the but it is systemic vasculitis involving multiple areas. So the the administration, the treatment is directly reducing inflammation, right? So and preventing cardiac complication. We must administer as soon as possible after the diagnosis is made of the Kawasaki's disease. So administration of the IV immunoglobulins 2 grams per kg over 12 hours, 2 grams. So Kawasaki's disease 2 grams over 12 hours is a rapid and dramatic symptomatic improvement in 90% of patients and prevents aneurysm formation in 95%. So this is very important. So a patient can be pulled out of the deathbed with this treatment. That's very important. And in addition to IV immunoglobulins, treatment with the aspirin 30 to 50 milligrams per kg per day, all the previous guidelines suggested high dose aspirin therapy during acute phase. Meta-analysis suggests high dose therapy 80 to 120 milligrams per kg confers no additional benefit over the anti-inflammatory doses. Okay, so following acute phase, aspirin dose is reduced to 3 to 5. That is 10 times it is reduced. Once daily for 6 to 8 weeks can be given. And a second dose is given, maybe given, that is of immunoglobulins, may be given if the patient remains febrile even after 48 hours of the initial dose, and because refractory fever may be a risk for coronary artery abnormality. So second dose can be repeated. And as many as 12 to 38% of the patients require second dose of immunoglobulins. And despite a retreatment IB immunoglobulins, 3 to 4% may still not respond. So this is a lower fraction, but still this is a considered. And a single dose of corticosteroids administered before does not improve any coronary coronary outcome. Okay, so there is no improvement on the coronary side. And however, for patients with persistent treatment resistance, rescue dosing of the coronary corticosteroids is being studied. Okay, and the use of the infliximab and also cyclosporin A, methotrexate and cyclophosphamide remains to be elucidated in for future prospective trials. Thank you very much.